Welcome to Dental XP, Treatment Planning Session, Parameters for Integration of Aesthetics and Function in Implant Dentistry, Session 2. As a reminder, Glorian is a 66-year-old female with an anterior open bite and posterior unstable occlusion due to advanced periodontal problems. When we look at the full mouth radiographs, lower arch is fairly stable. On the upper arch, we have pocketing that ranges from 8 to 12 millimeters. And on a closer look, we have 3 teeth on the right side and the upper left premolar with class 3 mobility. We know the prognosis of these teeth is hopeless. The question is, what are we going to do after these teeth are being extracted? Are we going to do bone grafting? Sinus lift? What kind of bone grafting is going to be implemented? What are the materials that are going to be utilized for such bone grafting technique? If we're going to place implants, what is the final implant to crown ratio going to look like? And is this something that's going to be maintainable by the patient? Are we going to require pink porcelain? On a closer look, we evaluate the bone levels and we decided to refer the patient to the endodontist. In order to do so, the teeth had to be splinted. The splinting took place because by placing a clamp without these teeth being splinted, all teeth will have come out. So the splinting took place, endodontic treatment was completed, and then we proceed with possibly orthodontic superruption of these teeth. We thought initially we should have a speech therapist to try to control the tongue thrust habit, and the orthodontist felt that it was not necessary. He was going to control that by placing these 2 mini brackets on the lingual. These buttons are going to train the tongue not to go forward, while the lower arch is being aligned. So they were kept throughout the orthodontic treatment. We can see the patient has an anterior open bite of about 3 millimeters. This is eccentric occlusion. And the upper left splint, where we're keeping the first premolar stable. Ready to start with the orthodontic treatment, we must grind the occlusal surface of the premolar to allow for superruption to take place. So the premolar is separated from the splint. The patient is giving a removable appliance to slowly superrupt with an elastic the premolar. While the patient is biting in this removable appliance, the posterior teeth are being intruded, and we constantly adjust the superruption of the premolar by grinding and making sure that it will not interfere with the occlusion or with the appliance. Patient comes to the office every 3 weeks to scale and root planning with anesthesia under these roots. After a couple months, with heavy probing, we can go about 4 or 5 millimeters on each side. So we feel that we have a healthier environment for the superruption to take place. 2 months later, the roots on the molar collapsed and there was no further treatment in this area. I'm a big fan of Malcolm Gladwell, who has written several books. I do recommend you reading them. One of them is The Tipping Point, Blink, What the Dog Saw, Outliers, David and Goliath. He has helped me think outside the box. On one of these books, he writes, "You start with a problem that you may not know how to solve, but you know there are certain rules you can follow and certain approaches you can take. And often, during this process, the intermediate result is more complex than what you started with. And then the final result is simple. And then there is a certain joy in making that journey." So we go back to the patient and we continue scaling these roots and adjusting on the occlusion to allow for the superruption to take place without interfering with the bite. Slow superruption and controlled movement is very important because, as you remember, these teeth had class 3 mobility. This is the result of the molar falling out and the roots collapsing on us. But you can see that the premolars are responding favorably to the slow, gentle superruption. We did not feel that TADs were going to help us with the anchorage, so we decided to use anchor plates for a more stable anchorage and start intruding the molars. This is done with 19-0 wires that will help intrude the molars while also occlusal adjustments are constantly being made. We can see that on the right side only the molars are touching, but we do not want to do any occlusal adjustment on these teeth because we know that these teeth are still going to be intruded. On the left side, we can continue adjusting the bite on the occlusal surfaces while molars are being intruded, upper and lower, but the occlusal adjustment is done only at the expense of existing restorations such as the crowns. This is where the patient is at this point. Orthodontic treatment is progressing quite well. We monitor radiographically that things are progressing as anticipated. You can actually see how the molar area has healed in a healthier, cleaner environment. The premolars also are responding quite well, and bone defects are being leveled. At this point, we can see the patient being very excited because the canines are actually touching. She does not remember when that might have taken place at a younger age. And we know that the molar on the right side still needs more inclination and a better occlusion. We can see how the patient's smile has changed in practically 2 years. And the final touches for orthodontic treatment is being implemented with the Sure Smile. Orthodontic treatment was provided by Dr. Jan Razdolski. This is how the patient started as far as the smile and the occlusion is concerned in 2010. And in practically only 2 years, we're able to change patient's smile. We know as far as the occlusion is concerned, is much more stable, healthier environment, and will address the functional and cosmetic issues during the next phase of treatment. How something appears is always a matter of perspective, and for us to achieve the results that you have seen can only take place with a team approach. You can see the patient's occlusion on the right side, fairly stable, and on the left side as well. So now we're ready to proceed with the next phase of treatment. Panoramic radiograph and periapicals are taken to evaluate the progress that has been achieved from the beginning. Bone appears to be fairly stable, but we need to let it settle for a few more months. We can see the occlusion we obtain on the right side and on the left side. On the left side we have provisionals on the upper left quadrant, and on the right side we know that these teeth will have to be extracted and eventually maybe some small bone grafting and possibly 2 implants for a 3-unit bridge. But what was at one point a very complex situation now is very simple. We see on the lower arch molars with large amalgams have been replaced with direct composite restorations, and on the lower left side we have replaced a couple of crowns. We take periapicals on the upper right side just to see that the bone is being maintained, as well as the upper left first premolar. After we let this settle for a few more months, we'll be able to proceed with the next phase of treatment. This is just a reminder of where we started on the upper right side and what the results that we achieved through endodontic and orthodontic therapy. Upper alginate was taken, the teeth were extracted on the model to fabricate a radiographic and surgical guide for the placement of 2 implants for a future 3-unit bridge. Markers will guide the surgeon where implants need to be placed. A smaller implant for the premolar area, slightly larger implant for the molar area. And as the implants are placed and the area is grafted, to have the proper volume for proper tissue profile on the final restoration, and then be able to actually close with a membrane and suture the implant site. Let it heal for a few months, and then eventually proceed with the final restoration. We can see on the radiographs minimum sinus lift was implemented for the posterior implant, none in the front implant. We prefer to take impressions with the open tray technique because we find it to be more accurate. There's no problems as far as having to reposition the impression post on the impression, and we do this routinely even with single restorations. We take the impression and we create the tissue moulage, replicating where the soft tissue is, the implant position. And we take a look from a lateral view where the implants are, mesiodistally exactly where we want them. Buccolingually, we would like the premolar to be a little bit more in the center of the fossa, even though a radiographic and surgical guide was utilized. So we don't like that position. But the original plan was to actually have a bridge that will be entirely screw retained. How are we going to manage this situation? We'll look at it from different angles. And unfortunately, the screw axis is coming too far buccal. So we decided on the final impression to customize the front implant. For the posterior implant, we're placing a multi-unit abutment. And on the front implant, we're going to modify that screw axis through having a lingually screw retained restoration. So the abutment in the front is waxed to have proper path of insertion with a multi-unit on the posterior implant. Once it's waxed, it's casted. We complete the casting, and then the laboratory technician is going to clean up that casting and mill it again for the proper path of insertion of the bridge. We evaluate this from the buccal, from the lingual, from the occlusal. Then we go back into the lab and we're going to proceed with doing some tapping for the lingual screw. So the tapping is done on a milling machine. We place the screw from the lingual. Laboratory work is done by my lab technician, Fujiki Toshiyuki. He places wax on the intaglio on the abutment, and then it's covered with the GC resin pattern, ready to be connected to the rest of the bridge. Then it's casted, and you can see the screw axis from the lingual with the screwdriver engaging the lingual wall for the bridge and stopping on the buccal wall on the inner segment of the casting. This gives us a very stable restoration. We evaluate this with a very passive fit with no tissue around it. Make sure we have a good fit, passive fit. And we also check this from the lingual. We place a screw on the posterior implant, and on the front implant we're going to verify with the screwdriver that the screw goes in on a lateral horizontal position. Then we're ready to proceed with trying this in the mouth. We need to verify that there's enough gingival embrasures to allow not only for the porcelain, but also for the patient's proper oral hygiene. At this point, and even when we took a final impression, we realized that the metal will be showing on the gingival margin on the molar area, but we did not want it to show any metal on the first premolar area. We look at the framework, trying to have as much metal support as possible, hopefully avoiding any porcelain fracture due to lack of support from the metal. You can see the screw axis on the first premolar, it's too far buccal. We view from the occlusal, it does not appear to be so bad, but not for the final contours that we wanted to create. We placed in the multi-unit abutment on the molar, and on the first premolar, the custom abutment. You can see with the slight inclination from the lingual, the screw access for the lingual screw. We're trying our metal framework to verify that it fits properly and that we have the proper space for gingival embrasures. And we need to verify that such access is viable and that the fit of the bridge is passive. So we proceed with the radiograph, and we place only one screw on the posterior implant, and this is what the X-ray shows, that we have a nice adaptation from our framework to the abutments and a transition onto the implants. To try one more step, we go with the lingual screw to verify that it sits without any kind of problems. A little bit early, but we take a shade. The patient wanted to whiten her teeth, but she also wanted to proceed with the final restorations. So we elected a shade that was a little bit lighter, with the understanding that the patient will be whitening those teeth. Then we have the final bridge in the mouth. Slight metal is showing on the gingival collar on the posterior implant. That personally I think could have been a little bit deeper, but we have an excellent result. The shade is lighter, as we know, because the patient wants to whiten her teeth. The bridge is entirely screw retained. The screw access on the posterior implant is closed with the tape and a posterior composite. And this gives us a final stable result. The amalgam on the molar will eventually be replaced. And this is where we are up to this point. And we do thank you for being at this session. Any questions can be answered through Dental XP, and you have my website and information with the office phone number. Thank you very much. We are very glad that you participated in this session.